My dear friends, in this video, I'm going to discuss about the cerebral salt wasting and how to differentiate and distinguish it from other common conditions, particularly in patients with brain injury following trauma, meningitis, encephalitis, etc. Let's begin with a case. A 70-year-old male presented with unconsciousness after fall at home. The GCS initially was E3V2M3. Pupils were sluggish. The blood pressure was normal. Heart rate was normal. The respiratory rate was mildly tachypneic. Saturation was nearly normal. But because of the poor GCS, patient was intubated and mechanically ventilated. The CT head revealed extradural hematoma without any midline shift. The patient was treated with IV fluids, mannitol as osmotherapy, and subsequently decompressive craniotomy was performed to remove the hematoma. Post-operatively, osmotherapy continued and patient was on ventilator. Subsequently, on day 3, the GCS improved. Patient was extubated after weaning from mechanical ventilation. However, after 2 days on day 5, subsequently again patient deteriorated. The GCS became 8 once again. There was diuresis with urine output exceeding 2.5 mils per kg per hour, and serum sodium fell to 116 millimoles. The potassium was slightly raised, but on the upper side of the normal range. The question is, what is the diagnosis and how to proceed? Now, it is very clear from the picture that this is one of the conditions where hyponatremia has set in following surgery, following an initial insult which was corrected by drugs and surgery, and subsequently the fall in sodium has occurred because of some other reason. Now, this can happen following two conditions. One, if there is an SIADH or syndrome of inappropriate ADH secretion, and the second condition is cerebral salt wasting. Now, cerebral salt wasting is found to occur commonly after aneurysmal SIADH, although it can occur after other conditions like other head trauma, other causes of head trauma like extradural hematoma, which was the cause here. If there is any intracranial neoplasm, if there is any metastatic neoplasm, infectious or carcinomatous meningitis, encephalitis, or even after any routine surgery. We know that whenever there is hyponatremia, there can be either an absolute fall of sodium, or there can be a fall of both sodium and water, with either water falling in excess of sodium, in which case the patient may develop a pseudo hypernatremia, although the actual picture is hyponatremia, or where the fall in water is less than that of sodium, and there also the two may fall and there is hyponatremia. Therefore, whenever there is hyponatremia, it is very important to distinguish into whether there is both water and sodium deficit, or there is water excess, or there is both sodium and water excess. And accordingly, it can be because of hypovolemia, that is hypovolemic hyponatremia, euvolemic hyponatremia, or hypervolemic hyponatremia. There are both renal and extrarenal causes which contribute to hypovolemia and hyponatremia, and they can be easily separated following the simple investigations. However, at times it is difficult to distinguish patients who are on euvolemia. And in those patients, and in some other cases of hypervolemia, it is important to measure the urine sodium. So once the urine sodium is measured and the concentration is found to be more, that means the urinary excretion of sodium has increased, then we can selectively find out the causes which are responsible for hyponatremia. When we have to distinguish between SIADH and cerebral salt wasting, it is very important to remember that in both conditions, there is excessive urinary loss of sodium and there is hyponatremia. But in SIADH, the volume status is either normal or the volume status is increased. That is, patient is either euvolemic or hypervolemic, whereas the volume status is depleted after cerebral salt wasting. So, in SIADH and in cerebral salt wasting, the urinary sodium is equivocally elevated, and the uric acid, that is both in the blood and the urine, uric acid in the blood is low. The fractional excretion of phosphate is low in SIADH and elevated in cerebral salt wasting. But more importantly, the serum urate levels, which were low, continues to remain low even after correction of sodium in patients with cerebral salt wasting, but they become better in patients with SIADH. And that is why the fractional excretion of uric acid becomes normal in SIADH, whereas they remain high in patients with cerebral salt wasting, despite the correction of sodium. So if we can just try to differentiate these two, we can understand that measuring the volume is absolutely important, because the treatment is totally different in cerebral salt wasting and SIADH. In one case, that is in cerebral salt wasting, we have to generously administer fluids and correct the hypovolemic state, whereas in SIADH, we have to restrict excess administration of fluid so that the patient does not become hypervolemic. So cerebral salt wasting is more often a hypovolemic state, in contrast to SIADH after surgery, trauma, or aneurysmal subarachnoid hemorrhage. Now, there are two theories as to what causes cerebral salt wasting. Although it is not very clear out of these two theories which one is a predominating cause, because there is no conclusive evidence to suggest that either of the two is the dominant cause in some patients or not. The first theory states that the brain releasing brain natriuretic peptide after injury enters the systemic circulation because of disrupted blood-brain barrier. This brain natriuretic peptide acts on the collecting ducts of the renal tubules to inhibit sodium reabsorption as well as decrease the release of renin. So that is one, and that is the reason what causes hyponatremia and excess of urine excretion, increase in urinary sodium. The second theory states that it is because of the injured sympathetic nervous system, which can no longer promote sodium reabsorption and stimulate renin release due to injury to the hypothalamus. So please note that the theory 1 states that it is the decrease in the release of renin, whereas the theory 2 states it is because of the stimulation of the renin release because of injury to the hypothalamus. So whatever may be the consequences, both finally reduces sodium reabsorption, which accounts for the fall of serum sodium. And what exactly causes the rise in urinary sodium is not so well explained by theory 2, but partly explained by theory 1, but still it is not conclusive. And therefore, we can say that the etiology of cerebral salt wasting is still not completely understood, or there are many gaps in the theories about its actual etiology. If we measure, if you try to focus on the diagnostic modalities, there are certain investigations that help us to clinch the diagnosis if they are interpreted properly at the right time. We know that in serum sodium level, there will be hyponatremia in both SIADH and cerebral salt wasting. Serum osmolality will be low because of hyponatremia. The urine sodium level will be elevated more often in cerebral salt wasting, but also is also usually elevated in SIADH. It may not be. Urinary osmolality is elevated in both, but it is the fluid volume status which tends to be hypovolemic in cerebral salt wasting, but either euvolemic or hypervolemic in SIADH. Urine output is reduced in both cases. Central venous pressure can be either normal or increased in SIADH because, obviously, because of this euvolemic or hypervolemic state, and the same will be decreased in cerebral salt wasting. The fractional excretion of uric acid, which I have mentioned, returns to the baseline, is more than 12% initially, but as sodium returns to the baseline after correction, this decreases in case of SIADH, but it stays elevated in cerebral salt wasting. I'm coming to the reason in the next slide. And also the fractional excretion of phosphate is normal, that is less than 10% in SIADH, but it is usually more than 20% or at least elevated in patients with cerebral salt wasting. So urine sodium in cerebral salt wasting is typically above 40 milliequivalents per liter, and urine osmolality is elevated above 100 milliosmoles per kg. So this is often important in bringing us closer to the diagnosis once we look into the other investigations. Now, I said that uric acid excretion is a measure which can be used for differentiating cerebral salt wasting and SIADH, because both conditions are associated with a low serum uric acid level and high fractional excretion of uric acid. But the key differentiation in these two conditions, you have to remember, is that in patients who are having SIADH, they have a serum uric acid and fractional excretion of uric acid that normalizes after correction of the serum sodium level, whereas the uric acid level remains low and uric acid excretion remains high in patients with cerebral salt wasting despite correction of hyponatremia. And this is because in SIADH, the sodium reabsorption in the proximal tubules is decreased because of an expanded extracellular fluid volume. But in cerebral salt wasting, solute diuresis occurs because of impaired urate transport in the proximal tubules. So the site is proximal tubules, no doubt, but the mechanism by which diuresis occurs of the uric acid is different in CSW from SIADH, and that is why it is not corrected, does not get corrected even after the correction of sodium in CSW, but it gets normalized after correction of sodium in SIADH. Now, the treatment of cerebral salt wasting and SIADH is very different, as CSW typically occurs after aneurysmal subarachnoid hemorrhage, although it may occur after other conditions like tumor, meningitis, etc. The first treatment strategies are usually targeted at treating the underlying SIADH and aneurysm or any other CNS insult that has catapulted this condition. Normally, isotonic fluid provides the fluid as well as helps to restore the body's sodium stores in mild to moderate cases. But when the cerebral salt wasting is of moderate to severe with moderate to severe hyponatremia, then more aggressive sodium replenishment is required with either 3% hypertonic saline or salt tablets 1 to 2 grams thrice a day, and also limiting the free water intake. However, many have advocated the use of fludrocortisone also for the treatment of cerebral salt wasting. But it is very important to watch for the sodium when correcting hyponatremia, because if there is hypernatremia, there is again the increased risk of central pontine myelinolysis and all other conditions, including seizures, aches, and etc. after during correction of sodium. Now, fludrocortisone, how does it work? Fludrocortisone exerts its effect by stimulating this release of sodium and water in the reabsorption of sodium and water in the distal tubules, which leads to expansion of the extracellular fluid volume. When this fludrocortisone therapy was used in patients with subarachnoid hemorrhage, less natriuresis occurred and sodium balance was achieved more frequently. So this has been found and reported in large trials, and volume depletion and hyponatremia are preventable in patients who are treated with fludrocortisone. And that is the rationale behind advocating the use of fludrocortisone in patients with cerebral salt wasting. However, use of fludrocortisone is not complication-free, and the most common adverse effect associated with fludrocortisone is hypokalemia. So it is important to know that once euvolemia is achieved, the goal of therapy is to maintain a positive salt balance and prevent further volume depletion by matching the urinary output with volume repletion. Once we are able to match it closely, then it gets corrected. So what should be the length of therapy for cerebral salt wasting? This entirely depends on the clinical course of the hyponatremia and the underlying pathology associated with the cerebral salt wasting. But it has been seen that once the underlying pathology is rectified or corrected, cerebral salt wasting usually remains a transient condition that resolves nicely within 3 to 4 weeks, and long-term therapy is usually not needed. However, brain natriuretic peptides have been described to remain elevated for up to 2 weeks in cerebral salt wasting, and therefore their measurement also helps us not only to prognosticate the patient, but also to distinguish initially from SIADH. It is an ancillary aid which can be used to differentiate it from syndrome of inappropriate ADH secretion. So my take-home message is that hyponatremia in the setting of a CNS event is a diagnostic challenge many a times to the physicians, as both SIADH and cerebral salt wasting can be likely etiologies. Volume assessment, along with levels of brain natriuretic peptide and changes in fractional excretion of uric acid, may help us to differentiate between these two conditions. But it is important to understand that volume status is not always clinically apparent in every patient, and therefore it is important to consider cerebral salt wasting in addition to SIADH in patients who present with hyponatremia and an intracranial process. However, a correct and timely diagnosis is very important, and this can help us to get a good outcome. Thank you very much.